Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspective and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it.
Thank you for joining us for this podcast on immunodeficiency and otolaryngology. This podcast is a collaboration with the Allergy, Asthma, and Immunology Committee. I'm Matt Ryan, a rhinologist at UT Southwestern Medical Center in Dallas, and today I'm joined by Dr. Antoine Azar. Dr. Azar, tell us a little bit about you.
My pleasure to be here. I'm Antoine Azar. I'm an allergy immunology physician, and I direct a center for adult primary immunodeficiency at Johns Hopkins in Baltimore. So I see a lot of patients with immunodeficiency disorders, whether primary, secondary, and a lot of these patients do have problems with sinus and ear disease.
Well, thank you for joining us. I'm looking forward to picking your brain and learning more about immunodeficiency.
My pleasure to be here.
My first question for you is, why should otolaryngologists be familiar with the primary humoral immunodeficiencies?
Often patients are going to present to the otolaryngologist who have an immunodeficiency, and they may have their first presentation to an otolaryngologist, whether they have recurrent respiratory infections, sinus infections, ear infections, and these disorders are important to be thought of and recognized. Immunodeficiency disorders are not uncommon. They can occur in people of any age as well. And as an otolaryngologist, you may be seeing these patients for the first time.
And that is a question I had. How common are the primary immunodeficiencies?
So it's estimated that about 1 in 1,200 individuals have some form of primary immunodeficiency. Some of these are more common. For example, selective IgA deficiency occurs in an estimated 1 in 500 individuals, and some of them are less common. But these are not rare disorders.
And do we know how common they are in patients who have chronic or recurrent sinusitis or, say, recurrent otitis media or chronic otitis media?
So we have some data. People have published a number of reports, patients with chronic sinus disease and the prevalence of immunodeficiency. There's a wide range depending on the population, depending on how the diagnosis was made. But for example, there was this meta-analysis over 1,000 patients who had chronic rhinosinusitis persistent despite the sinus surgery and despite medical therapy, and approximately 23% of these patients were found to have some form of antibody deficiency disorder.
That's really high. I'm actually amazed by that.
It is, and this is a patient population who have recalcitrant sinus disease and who have failed therapy. There are some other reports on patients with recalcitrant sinus disease who were found to have a specific type of immunodeficiency called CVID, or common variable deficiency, and the range was anywhere from 0.5 up to 10% of these patients with refractory rhinosinusitis who had this form of immunodeficiency.
And in those patients that have refractory rhinosinusitis and immunodeficiency, what are the immunodeficiencies that are involved? Because there's a bunch of those, right? Which ones are the relevant immunodeficiencies in chronic sinusitis?
So there's many immunodeficiencies, probably close to 500 different types of immunodeficiency disorders. But the most common by far is what we call the predominantly antibody deficiencies. These are immunodeficiencies that affect antibody numbers and antibody function. And these are the ones that are by far most common. They would be most commonly found in these patients with recurrent sinusitis or ear infection.
And so, given that pretty high prevalence of immunodeficiency in chronic rhinosinusitis patients, or at least in those that are refractory to our standard treatments with surgery and medications, how do we identify those patients? Or are there any red flags? Or what are the clinical scenarios in which I ought to become suspicious that my patient might have an immunodeficiency?
Yeah, I think what you said, suspicious, is a very good term. I think this is the most important first step as an otolaryngologist is when you're suspicious that there may be something going on with your patient, to have a low threshold to check these patients or refer them for evaluation of immunodeficiency. I think this is key in recognizing, when to check your patient, because you may be able to identify patients early on or really reduce the length of time to diagnosis. There's a number of features to look for. I would say that overall immunodeficiency patients present with infections, which can be recurrent, unusual, severe. However, they can also present with autoimmune disease, malignancy, inflammatory disease. So a combination of recurrent, unusual infections in combination with these other disorders should generate the suspicion for immunodeficiency.
If a patient has a humoral immunodeficiency, an antibody deficiency, can that manifest as an isolated sinus problem, or do these patients have other types of infections as well?
They could manifest as recalcitrant sinus disease only. But of course, if you have somebody with sinus disease and they've had a pneumonia, they've had other infections, they've required multiple antibiotics, they've been hospitalized, they've had meningitis or sepsis. Of course, the more infections you have, then the more likelihood that they're going to be immunodeficient. That will lower your index of suspicion. But some patients can present with primarily chronic recurrent sinus disease.
So for an otolaryngologist, treating the patient with, let's say, otitis media problems or chronic sinusitis problems, are there specific bits of the clinical history that we ought to be asking about to try to parse out whether or not a patient may have immunodeficiency?
Yeah, a number of things to look for in history. Patients who have chronic documented sinus disease, patients who have recurrent sinus infections, 2, 3, 4 or more documented sinus infections per year. We have recurrent otitis in adults because there are 2 ear infections or more per year, and kids 4 or more infections per year. So the frequency of infections, the severity of infection, somebody with an unusually severe sinus or ear infections, for example, requiring multiple antibiotics before it clears, requiring intravenous antibiotics, requiring multiple courses of antibiotics. So the severity of infection is also something to consider. Overall, I would summarize it as a practicing otolaryngologist. If you see a patient with unusual features of infection, that would be the key word probably. Unusual frequency, unusual severity, unusual duration, unusual complications, or unusual organisms. All of these should raise your suspicion for immunodeficiency.
So if I have a patient like that, let's say a treatment-refractory chronic sinusitis patient who also has a history of an adult with otitis media episodes, maybe a history of a few pneumonias, and I'm starting to become suspicious that that patient may have an underlying immunodeficiency, what are some of the things I can do as an otolaryngologist to sort of get to the bottom of that or screen the patient or otherwise evaluate them? So really what I'm getting at is I want to find out what screening tests should I be ordering as an otolaryngologist to try to rule in or out an immunodeficiency?
Yes, I'll talk about, of course, the good history, as always, and some screening labs as well. The history, do they have other infections besides their sinuses and ear infections? For example, have they had pneumonia, sepsis, meningitis? Have they been hospitalized for infections? Have they needed antibiotics for any other reason? So that other infection history is important. Do they have any chronic lung disease, for example, bronchiectasis? That's such a red flag for patients with immunodeficiency. It's one of the common complications in immunodeficiency patients, and this represents a long-term and irreversible disease in the lungs. Do they have any history of autoimmune disease in the patients or their family members? Do they have a history of malignancy? So all of these will give you clues in their history as to what your suspicion is for immunodeficiency as well. Now, in terms of screening labs, some really easy basic screening labs to start with would be CBC with differential and serum immunoglobulins, IgG, AME. These are easy, cheap, simple to obtain, and they would be a very initial place to start when you're suspecting an antibody deficiency disorder.
Are there any other tests that I, as an otolaryngologist, ought to be doing?
You could. If you start with these screening labs and they're normal and the patient is presenting with current sinus infections, and especially if they're having encapsulated organisms on culture, the next step is to look for functional defects in antibody production. And that would be by assessing patients' antibody response to vaccines. And one of the best tests we have available right now would be the pneumococcal vaccine. So you can check 23 pneumococcal titers, and if they are really low, you can provide the Pneumovax, monosaccharide Pneumovax 23 vaccine, and assess the response a month later. If you have patients who have normal immunoglobulins, but who have poor response, they don't make any antibodies to the pneumococcal vaccine, this is called specific antibody deficiency. It means they're not able to produce antibodies.
So we can get a CBC with differential, total immunoglobulin levels of all those different classes, and also draw the basically pneumococcal antibody titers for 23 different pneumococcal serotypes. If that comes back normal, is that enough? Do people need to dig deeper, or is that when it's time to refer to an immunologist?
Yeah, another screening test you could do is looking at the numbers of the T, B, and NK cells. So looking at all the subsets of lymphocytes.
Okay.
That's also an easy test done by flow cytometry and commercially available. That will give you the numbers of subsets of lymphocytes in addition to the antibodies, in addition to the antibody function. If you do all of these and you still have a clinical suspicion that the patient has an immunodeficiency disorder, then it would be very appropriate to send your patient to an immunologist for further workup.
All right, I want to backtrack a little bit and go back to patient's history. I've got two specific questions for you. One is, when we're talking about primary immunodeficiency disorders, these are genetic diseases that theoretically at least should run in families. How valuable have you found family history to be in helping you pinpoint patients with immunodeficiency?
Yeah, very good point, a very good question. Since a lot of these disorders run in the family, if someone in the family has an immunodeficiency disorder, that certainly significantly increases your suspicion for an immunodeficiency disorder. So obtaining family history, whether of immunodeficiency, recurrent infections, or even autoimmune disease, is very relevant. But I will also say that the common misconception is that you're either born with an immunodeficiency or you can't have it. And this is really not true. A lot of these disorders are diagnosed in adults.
Yes, and that is a very curious thing. So I'm going to pick your brain about that, because if you have cystic fibrosis or sickle cell anemia, you have a genetic disease that becomes manifest very early in life. But it's not that way with humoral immunodeficiencies, right? When do these develop over the lifespan if they don't develop in infancy?
Yeah, so some immunodeficiencies, for example, the severe combined immunodeficiency, where patients don't have T cells. Patients are born with a severe combined immunodeficiency and it manifests in the first few months of life. However, with the antibody deficiency syndromes, they could manifest at any age. In fact, only a small minority of patients with antibody deficiency have a known genetic defect. It's a small number. A lot of the other patients we still do not know or do not have a genetic defect causing these illnesses. And it's possible that there's a multifactorial number of factors contributing to this immunodeficiency, whether genetic, environmental, which can manifest at any age.
Take-home messages I'm getting from you is, one, just because there's not a family history of immunodeficiency does not in any way exclude the fact that my patient might have an immunodeficiency. And then the second is that where they are in their lifespan also isn't particularly relevant. One can develop CVID, let's say, common variable immunodeficiency, in their 70s, theoretically.
Absolutely. And that's sometimes people don't think about it because the patient is in their 50s or 60s or 70s. But yes, you can be in your 70s and be diagnosed with CVID for the first time. I have a lot of patients like that. And that's really important to recognize that if somebody is an adult and does not have a family history and you have a suspicion, you should still screen this patient.
We talked a little bit about referral. So you mentioned that if we do some screening tests, we find some abnormalities, then we need to probably refer the patient to someone who's an immunodeficiency expert, right? Or if we did our laboratory studies and they come back normal, but we're still suspicious, that's another reason for referral. Are there other scenarios that you can think of where otolaryngologists ought to be partnering with an immunologist to assist them in working up patients or treating them?
Yeah, and I work very closely with my otolaryngology colleagues and for a lot of patients with recurrent infections and complex sinus and airway disease. But you said it right. If you have a strong clinical suspicion that the patient is unusual enough, that's the reason for referral. Doing those screening tests, if you have somebody, for example, with a low IgG level, that's another reason to refer to an immunologist to proceed with additional workup and to rule out CVID. Because if you do diagnose an antibody deficiency, there may be some additional treatment options that you can offer these patients.
So I want to review the treatment options with you, and we'll take some of the common immunodeficiencies and just discuss a few, but the ones that are most relevant for otolaryngologists, I think. Let's start with IgA deficiency. How is IgA deficiency treated?
IgA deficiency is the most common primary immunodeficiency, approximately affecting 1 in 500 individuals. However, a lot of patients are asymptomatic. And another important point about IgA deficiency, it's defined as an undetectable serum IgA. It's not just a low IgA. it's undetectable. It's usually below the lowest limit of normal that's detected, lowest limit detected by the lab, which is 5 or 7 milligrams per deciliter. So that's what selective IgA deficiency is. For patients who are symptomatic with recurrent respiratory infections, recurrent sinus infections, the first thing is, of course, topical therapy for these patients. Vaccination, for example, pneumococcal vaccine. I usually assess these patients' response to vaccine as well. For a small subset of patients who, despite topical therapy, vaccinations, who continue to have recurrent documented infections, these other patients can be treated with either PRN antibiotics or, depending on how frequently they're getting infected, you could use prophylactic antibiotics, but that could be for a small subset of these patients.
So prophylactic antibiotics, I'm familiar with. We used to use that back in the day for children with chronic otitis media with effusion, and we would start them on antibiotics for a period of months on the misguided notion that somehow there's some bacteria in that effusion keeping the inflammation going, and even though the effusions weren't purulent, there was no frank infection, we thought that that was beneficial. What does prophylactic antibiotic treatment do, or when do you employ it in those select cases you mentioned of IgA deficiency?
So first of all, you want to make sure that you have documented recurrent sinus disease. Okay, by imaging, rhinoscopy, cultures. So you do documented recurrent sinus infection. That's key because, as you very well know, there's many other reasons for sinus disease, whether rhinitis or anatomical abnormalities and so on. So are we truly dealing with the recurrent infections? So once you have that documented, then this is where I would use that antibiotic in patients where you have really documented recurrent infections.
So that's IgA deficiency. Let's talk about CVID. What are the treatment options for a patient with CVID?
Yeah, so CVID is the most common symptomatic primary immunodeficiency. It's the prototype of the antibody deficiency syndromes. And I'm going to say that, as the name implies, common variable, that's very variable. Patients on a spectrum of having milder illness manifest primarily as infections that are very well managed with immunoglobulin therapy, versus patients who have a variety of other complications, including autoimmune disease, inflammatory. So it's very variable in its presentation and its severity. And CVID affects approximately 1 in 25,000 individuals, probably more than that, but that's what we have based on survey data. CVID requires that the patient has a low IgG level. They often have a low IgA and IgM level, but that's not enough. It's really important to assess the patient's ability to produce antibodies as well and to rule out secondary causes of low immunoglobulin. So I just want to emphasize that the low IgG alone does not mean that the patient has CVID. You got to make sure that you proceed with this other workup. Going back to your question, once you do have a diagnosis of CVID, the main treatment for it is with immunoglobulin replacement therapy. And this can be given intravenously or subcutaneously. And once you have a diagnosis of CVID, patients will likely require the therapy lifelong.
So you're an immunologist. I'd like to get your opinion about what your experience has been with sinus surgery and CVID patients. Do you have an opinion, pro or con, about what sinus surgery can do for those patients?
I co-manage a lot of my patients with sinus disease with my otolaryngology colleagues, and I emphasize that the way I look at sinus surgery is that it is complementary to medical therapy. If you treat these patients with sinus surgery alone without medical therapy, you're probably going to have recurrence. So we emphasize the use of medical therapy, maximize medical therapy, and my view of sinus surgery is those patients who fail medical therapy after maximization, these are the patients who would be candidates for sinus surgery. And in general, it would be a minimally invasive sinus surgery in order to minimize any injury to the mucosa.
So we've talked about IgA deficiency, common variable immunodeficiency. Let's talk about specific polysaccharide antibody deficiency, also sometimes called specific antibody deficiency. This is I believe, a newer form of immunodeficiency, or at least it's more recently recognized. Tell us about how that's diagnosed, and then also what are the treatments that an immunologist would employ for such a patient?
Yeah, specific antibody deficiency is a little bit more tricky to diagnose because the patients look like they have a normal immune system. They present with recurrent, frequent infections, but they have normal immunoglobulin levels. However, the main defect is they're not able to produce antibodies when you stimulate their B cells with a vaccine. So the way to diagnose these patients is to vaccinate them with a polysaccharide vaccine, which right now the best available we have is Pneumovax 23, and assess their antibody response. And it can be also difficult to interpret that antibody response in these patients. There are some consensus statements on how to interpret these antibodies in general. If you have somebody who have very few numbers of serotypes that go up to a protective level after the vaccine, this is where we consider these patients to have a specific antibody deficiency.
And I think my lab at my hospital actually defines what is a protective level of antibody. Whether we're ordering a test for pneumococcus or tetanus or some other pathogen for which we ought to be able to detect antibody level. And I want to say it's around 1.9 milligrams per deciliter. I don't know if I'm right on that. You mentioned sort of numbers of the different serotypes that have protective levels and that there's some consensus statements on that. My recollection, there was something like over 50%, or does it need to be higher than that, where we have a protective level for these 23 different pneumococcal serotypes?
The protective level sometimes may vary from lab to lab as to what they define it. In general, 1.3. 1.3 is what is considered to be a quote-unquote protective level. If you have somebody with 2 or less titers that are in the protective range, this is what we call a severe reduction, antibody reduction, severe antibody deficiency. It's generally considered that 50 to 70% or higher that are in the protective range is what you consider a normal response.
So for these patients, if you diagnose a patient with specific polysaccharide antibody deficiency, what is the treatment approach for those folks?
So specific antibody deficiency, the initial treatment is similar to selective IgA deficiency. Topical therapy, vaccinations as appropriate, and depending on the frequency of infections, severity of infections, PRN antibiotics. Now the next step for patients with documented recurrent infections would be prophylactic antibiotics. There's a subset of patients who fail antibiotic therapy. For those patients who have documented recurrent infections, who have failed a course of prophylactic antibiotics, perhaps for 6 months or more, who may benefit from immunoglobulin replacement therapy.
So it sounds like immunoglobulin replacement therapy isn't necessarily first-line treatment for specific polysaccharide antibody deficiency.
That's true. Immunoglobulin replacement is first-line treatment for CVID, but for specific antibody deficiency, it's not first-line therapy.
I also want to talk to you, Dr. Azar, about an immunodeficiency that's somewhat controversial, that in the otolaryngology universe has been something that we've thought about and cared about, and that is IgG subclass deficiency. I would like to get your opinions about, one, whether that is actually a clinically relevant disease state. Two, have you talked to us a little bit about the nuance of IgG subclasses? And then three, explain if there are any IgG subclass deficiencies that are clinically relevant and how you would treat that.
Yeah, so IgG subclass deficiency, as you said, it's more controversial and there is less data on the significance of the IgG subclass deficiencies. What is more important in evaluating patients is actually the total serum IgG level. So if you have one subclass that's a little bit low, one a little bit high, but they're adding up to a total IgG, and if there's good antibody function, so if you have normal total IgG, ANM, patients are producing good antibodies to polysaccharide pneumococcal vaccine, then this is what would be significant. So in this scenario, you have one IgG subclass that's a little bit low, that's probably not clinically significant. Now, something I very infrequently check IgG subclasses because I think their clinical significance is really not as important as the total IgG antibody response.
That is an important take-home message, that checking IgG subclasses is not particularly valuable. Do you agree?
In most of the cases, yes, it is not a valuable test. What's much more important is total serum IgG and the antibody response.
So we have reviewed a little bit about the importance of primary immunodeficiencies in otolaryngology practice, because we are at the front lines taking care of patients with recurrent otitis media, recurrent and chronic sinusitis. And so we're in a position to identify these patients in our practices. And as Dr. Azar pointed out, the most relevant immunodeficiencies are actual antibody deficiencies. We've discussed 3, at least, different antibody deficiencies that are relevant for otolaryngologists. We've talked a little bit about when to refer to an immunologist because, as you point out, multidisciplinary collaboration is extremely important to take good care of these patients. And one treatment option that you guys, as immunologists, can provide is immunoglobulin replacement therapy and global evaluation and treatment of all the other manifestations. This is not necessarily otolaryngology relevant, but you did point out that patients who have immunodeficiencies will sometimes have other immune system problems, autoimmune disease, for example, or predisposition to malignancies. And so we we have to think not only about the patient's quality of life, but also the fact that some of these conditions, if not recognized, can be fatal. I'd like to close, Dr. Azar, with a question to you about that you want, or what you think otolaryngologists could or should do better in helping to take better care of immunodeficiency patients.
You summarized this very nicely. But I think as an otolaryngologist, having this index of suspicion when you have patients presenting with these symptoms or cancer or disease and checking for possible immunodeficiency, that's a very big initial step. Because like you mentioned, these patients are going to be coming to you with lower respiratory infections. Some important points to mention as well, to reiterate, these are not very rare disorders, and they can occur at any age. Thinking about immunodeficiency, it can occur in patients of any age coming to you. And knowing that if you identify an immunodeficiency in this patient population, there's a lot of additional treatments that can be done in collaboration with immunologists that can significantly improve the patient's quality of life.
Well, Dr. Azar, this has been a lot of fun. Thank you for joining us for this podcast, and I hope you all enjoyed it as well.
Thank you. It's been my pleasure.